along the top here, in the blue line, is what EMS and fire do today in terms of data analytics. I'm going to pick a little bit on fire services in this regard, but EMS is guilty of it too. It's not quite as bad. We're kind of obsessed with counting things. So like shoot times and response times, which may or may not be relevant, and the number of whatever that we did. Show of hands if you count Narcan administrations. Show of hands if it matters. Yeah, so the funny thing is, it doesn't. In fact, I've got a whole paper that I'd love to get everybody's email on here and send to you, but this is in a final draft now that I'm going to be sending out all over the place, especially at the top level of the states. It's actually a really shitty metric. That's just what it is. Narcan administration is being used as a substitute to essentially look at how addicted a regional population is, but you give Narcan for all kinds of reasons, like by protocol, or because your patient's unconscious and you don't know if they stuck something in their body, or because they did the last time you saw them. And we have no way in NEMSIS of documenting whether it worked. Simply not checked. This is so bad that agencies are finding themselves on lists of, worst or top 10 worst in the state of Colorado, for example, for opiate offense, when it turns out they only had 6 patients who actually had an opiate problem. This is going to get me started on the state of California. California's core measures, under our consulting team, last October, we identified 16 pages worth of mathematical errors in the California core measures. In October 2018, these had been published in 2017. What the hell have we been counting for the last, say, 18 months and using to make policy? Right? So the fact that we count stuff in a discrete fashion and don't usually do it to do anything useful with it, and in some cases don't really realize that it has latent errors in the calculations, is a pretty serious problem. One thing that is where this can go is, wouldn't it be neat if you could, for example, look at the incidence of certain clinical issues, ICD-10 codes, pick them that way, in a given region over a time of day, certain demographic groups, looking at historical patterns and start to say, well, how do we need to engage our community? Food deserts, healthcare deserts, all of these issues are very, very real, and a ton of the data about what's going on in the context is basically collected by the folks who are roving around it, taking care of sick people with, light bars and sirens and stuff, and getting invited into people's homes because you wear a different badge than guys with a different uniform. That information doesn't get tracked, but it could. So what if you could start taking that patient data that you are encountering and you can start stringing it along over time? So one of the persistent myths, I still don't understand where this came from, but there is this myth that electronic health records are somehow person-specific, whereas EPCRs are incident-specific. Show of hands if you've seen that in an industry magazine, publication, etc. Yeah, it's total hogwash. It's the weirdest. I don't even know where that concept came from. But if you think about Epic is not a scrolling stream of information. Like, it's just not the way it works, right? If you think about the idea that you go into a doctor's office, he takes out a yellow pad, just kind of like that one, right? And sits down with you, and he says, let's see what happened to you 3 months ago when I saw you. I'm going to flip to a new page, and I'm going to put the one today. I'm going to track your encounter today. And then he goes and puts it into Epic, but that's a whole separate process. The fact is that person-specific or patient-specific documentation is a collection of encounters, right? It's not one long stream. Everything is contextualized by what came before. So what it takes to turn an EPCR, which is an incident record, into a patient record is like a medical record number, and the ability to keep that contained over time. Every one of you can do that. You could do it by internally assigning a number to your own patients. There are certainly technology systems that can do that for you, but we have identifiers that we can do that. By the way, what would you consider to be the single most unique identifier that you could use to track a patient over time? Anyone? Who said it? Is it? Have you used it yet? I've had one department. You are now department number 2 that's even mentioned that in a conversation. I mean, really? We can use our fingerprints to get into our phone. So the first time this was brought to me was probably about 4 years ago, by a little department down in about 20 miles or so from the Mexican border in Arizona. 2 stoplight towns. And the chief of the department at the time literally says, I have a drunk person problem. He's got people coming in, mostly undocumented, many don't speak English, that work all week at factories and whatnot around the area, get paid on Friday in cash, drink it away, pass out in the street. So I don't care what their documented status is. I'm going to see them again next week, and it'd be really great if I knew who they were. The information isn't going to criminal justice, but wouldn't it be neat if, like, while they're posted against a wall somewhere, I could like take their fingerprint and go bloop and pull up their health information from the last time I saw them when they were conscious enough to give me some information. And yet our industry is talking about getting off of paper records. Like, that's still where we are. Is a remarkable dichotomy. There is not an EPCR in this room or used in this room that can't be strung together over time to give a picture of the patient's care. Why aren't we talking about that? Why aren't people demanding that of their EPCR vendors? And if they did, how quickly would they get around to doing that, or finding a way to do that by handing their data off to someone who could string the data together for them? And if you could do that, what could you track about that patient? So, for example, again, in the context of patient-specific as opposed to incident-specific data, for whatever silly difference that is, one of the things that E.M.S doesn't track is compliance with medication, right? So you track what medications people are taking, right? That's in the E.M.S record, but not whether they are taking it as they're supposed to, and not whether they're taking it over time as they're supposed to. But I talked about creating, documenting value to create things like a community paramedicine program. And if you're familiar, or show of hands if you're familiar with the concept of an actuarial risk table. So we're going to talk a little bit more about this, but the actuarial risk tables, in a nutshell, is where insurance companies get their rates. A table that determines how quickly you're going to die. It's kind of a less nice way of putting it. But it's looking at risk over time and based against certain demographic considerations, whether or not you smoke, and so on and so forth. Well, if it turns out that, for example, you can take a patient who has, say, 6 different medications, 10 medications, a bag of medications, right? And you know that they're basically compliant with none of the drugs they're supposed to be on. Maybe they're compliant with 1. And then over an engagement of, say, 3 weeks, 4 weeks, 6 weeks, you can now get them compliant with 8 or 9 out of 10. Money falls out of the sky, right? That you have reduced the risk of that patient in a measurable fashion vis-a-vis insurance. If you can take someone from 6 packs a day to 2 packs a day, money falls out of the sky because that patient has become less risky and less expensive with respect to the actuarial tables that insurance companies use to set rates. While it doesn't necessarily happen in 30 to 60 days, the literature demonstrates a measurable savings on that patient over time. It actually does not take 30 days. It takes 365 days. And anyway, going back to the mention that community paramedicine programs 1.0 have largely died, it's because they snapped to the readmission provision, the 30-day readmit. Turns out it's bunk. Doesn't work. It's a good idea, just won't work. And the reason makes a lot of sense, because if you think about a patient who is taking those medications and is not compliant with them or is smoking 6 packs a day is probably not going to the doctor all that often. And so all of a sudden you put them into a managed care program under the premise that you're going to save the system money. You just made them incredibly expensive because you're now taking them to the doctor. You're making them healthier. And didn't that come up yesterday in the conversation, right? The concept of making someone healthier is not measured, certainly not in E.M.S. We don't have any metrics for what it actually means to make them healthier. So as we start to look at stringing the data over time, we can. Because you can see over 30, 60, 90, 180, 365 days, how have you gotten their medication adherence to comply? Is their weight changing? Right? Again, if we're obsessed with counting things, let's talk about counting things over time. So, the amount of water accumulation in somebody's body, how is their heart rate fluctuating? And is it stabilizing within an acceptable range over the encounters you're going to have with folks? You don't even need a separate VCR system to do that. You don't need a separate anything. You just need Excel to do that. You capture all this data in your EPCR today. Now, there are some tricks and tools and whatnot that other programs can bring to that. It doesn't benefit me to tell you that you don't need me to help you do that from a technical perspective. But we haven't been doing that. Bless you. So, so to me, this all gets back to sort of the understanding of how we ended up in this place where the technology systems don't talk to each other, where they seem so mystical and mystified and self-contained and so on and so forth. And as so many things do, it sort of comes down to government. Is what it is. Government's not really great at messaging what it's trying to accomplish. And unfortunately, so I had a professor who ironically was a liberal energy professor, but at Carnegie Mellon, and he had this sort of ironic phrase for a guy who's known for green energy, which he called Lester Lay's iron law of government. It was when government gets involved, everybody loses. What ended up happening, which I actually wrote an article predicting back in 2016, and it was one of the few times in my career I can safely say I wish I was wrong, is that this was going to get worse, and it is, and it has, and it is, and there's an opportunity to fix it. But essentially, we have different colors of money at work here. Because, show of hands, have you seen the movie Contact? Jodie Foster? Oh man, you guys need to see that movie. It's a great movie. Okay, first rule of government contracting. Okay, why build one when we can have two at twice the price for everyone who's listening on the phone? So that's what we had. That's awesome that you got that. I'm so excited. Oh, I felt like such a nerd. So the context for the creation of something called the Office of the National Coordinator of Healthcare IT was a big rainstorm called Hurricane Katrina. What they realized was that doctors' offices in particular, and some other facilities, had health records all over the city. They just couldn't get to them because there was a whole lot of water in the way. And in other cases, they had servers that were waterlogged. And in other cases, they had buildings that were red tagged that they couldn't get into. And so there was this concept that if you could essentially build structures into the ways that healthcare information technology would be used, you would pay people to adopt them. And in the payments to adopt technology were tied to the measurable benefits you would get from using them. So, for example, the ability to provide a discharge note when someone is leaving the hospital and be able to say, this is what's been done to you, this is what you need to do next, and so on and so forth. I don't think it's too broad or blunt a statement to say that the funding that came from this built Epic and Cerner and Athena Health and sort of injected massive amounts of capital into these companies because doctors' offices and hospitals and so on all over the country literally were paid to adopt technology that met certain standards. And those standards were established by the Office of the National Coordinator of Healthcare IT. You guys didn't get any of that money at all. So by the time that the requirements came down for NEMSIS, that money was not there. The framework associated by the National Coordinator of Health IT under this framework called Meaningful Use is based on something called HL7. And I will just advance to a slide a little further down that we'll come back to, but HL7 stands for Health Level 7. It is essentially NEMSIS for electronic health records. That's what it is. So it's the data system on which the system is built. And because it was done under a different silo, the two systems grew up in parallel. HL7 is a very important system. It is international in its scope, so truly the ability to go anywhere in the world and have commonality among the data set. And there are so many things that are not known about it by E.M.S. that it's terrifying. And I'll give you an example. About a year ago, my company applied for an RFP in Florida, where is one of the larger counties in the state of Florida that required in its RFP that you are HL7 compliant. First of all, that's not a thing. HL7 is a language. It's not really a compliance structure. There are things that you do to be compliant with certain ways of using it, but in and of itself, it's a framework. It's a way of building stuff. More importantly, forgetting the fact that that's a detail most people wouldn't need to know, I wrote back to the procurement officers who were in charge of this bid for a very large county in a very large state and said, what version of HL7? And their answer was, there's more than one? ? How do you buy something without knowing what it does? How do you require something in a public RFP without knowing? Isn't that just an invitation to be lied to? Right? Because, well, sure, I'm HL7 compliant. Couldn't prove it because I wouldn't know what I have to prove. But the problem is not necessarily on the technology company to have ethics and stuff. It's kind of important there. But on the receiving side, how do you have any idea if it works if you don't know what it is? So to the degree that there is sort of this separate but equal standards on both sides of the handoff that aren't necessarily talking to each other, how do we know how to use them? And how do we know what they can and can't do? How do you know if the company that you're working with and putting all your, again, blood, sweat, effort, training, money, et cetera, into, and says it can share data with a hospital, how can you know whether it's working or not if you don't know how it works? And I'm not talking about knowing what the code looks like, but at least knowing that there's more than one version. Or, for example, knowing that this meaningful use framework that is required of all electronic health record systems in the United States right now must be on HL7 version 3. There is no such thing as a clinical document architecture on HL7 version 2. And this just, by the way, on the back page of the booklet that you have is a list of some of the clinical document architecture structures, which is what the basket of requirements that the meaningful use framework lays out. So you can see the variety that there are. Last October in California, a county that shall remain nameless, hired a consultant to implement a pre-hospital health information exchange because California likes reinventing the wheels. I don't really get it. But they decided they were going to do their own local project. Okay. So when I and a couple others responded to this and, again, asked the same question, which version of HL7 would you like? Because it hadn't specified. They said HL7 version 2, which was remarkable because no. So the folks are shaking their head. No, you do not want to. That's literally like saying, I'm really looking for an E.M.S version 2 EPCR. The consultant that they had hired insisted that the HIE was utilizing HL7 v2. Okay, maybe they are. Maybe it really is that old. But I pulled up the contract, which was published online for the county. And in the contract, it said they're exchanging data using CCDs. The clinical document architecture sets out these standards. They are all on meaningful use stage 3. They're all on, all meaningful use, and they're all HL7 version 3. How is it possible that the county's own consultant, which apparently works for or with the health information exchange in the county, whose own documents said that they need to have CCDs, which is HL7 v3, asked for HL7 v2 in writing, and then awarded that to a company that said that they would be able to do it? I won't actually tell you which company it is, but you might be able to guess. It is most amazing to me that is its moral hazard at its worst, right? Not only are they being lied to, but the person who is the one who is entrusted to make sure they have the right decision, didn't know what they were buying, got lied to, and at some point along the way, California will get awarded another $4.9 million grant to reinvent health information exchange, as they just talked about, on a listserv roughly a month ago. The public looks at your work as scoop and run, unidirectional. We know, everybody in this room, that data needs to flow in all kinds of directions. It flows outward to a billing company. It flows to the state. It flows back to your agency for QA, knowledge management, future training. It flows into the hospital. It flows to affiliated clinics. It might flow to an app that this person is carrying that they were prescribed by a doctor to make sure that they're keeping their blood sugars in line over time. Right? That information needs to flow in all kinds of places. And in order to do that, we need to have some idea that the data are common, that they can be shared, that they can be mined. Right, that you're not going to have separate but equal standards that don't touch each other, and that someone somewhere along the way making decisions is going to know what the heck they're talking about. If you can have those information sharing facilitated quickly, there's some really neat operational benefits that EMS and fire services get out of that. Right? Pre-registration of your patient at the ED. How long on average, just have a thought on this, but how long on average does it take you to wait for your patient? Right? How long do your crews wait with the patient to get taken to the hospital? So, true story, Montefiore Medical Center in New York City, one of the largest trauma centers in the United States. I was working with their EMS agency for a while, and they had never clocked that. They'd never actually measured their intake time. So I stood with the CIO of the ambulance, or CTO, CIO, whatever, nurse managers and IT folks in their ED and did a totally scientific calculation on an iPhone for like 15 to 20 minutes of how long it took. And it turns out it was about average. It took about 3.5 minutes, 3.5 minutes per patient. So kind of knowing the answer to this question, I turned to the hospital team and basically said, so what? I mean, big deal. It's only 3 minutes. Why do you need technology to facilitate? And they looked at me like I was insane and said, "Are you kidding? We did 13,000 patients last year. Save me a minute. Save me two. What at a hospital's per minute cost basis, what can you save me if you save me 2 minutes of administrative time that does absolutely nothing for me? It's not clinical benefit. It's all paperwork, right? Again, it's scanning and faxing and so on. And anyway, it's most remarkable. And then on the hospital, on the E.M.S. side, what would you be able to do from a trickle-down effect if you could get your crews back out in the field faster? Think about the opportunity to save 2 minutes, 5 minutes, 10 minutes on your turnaround times and how that would impact your organization when all you're really talking about is conveying administrative data that could be done electronically. I calculated this in Hartford, I watched in Hartford, Connecticut. I have some really neat pictures for 8 minutes. It took 8 minutes while the E.M.S. agency utilizing an EPCR literally read the content of that EPCR to the nurse who was entering it into Epic at that hospital, and she retyped everything they'd already written. How does that make any sense? When we can send that data over in a consumable fashion. So how do you do that? And why are porous standards dangerous? Why is simplifying too far dangerous? So it turns out that, again, separate but equal, but that doesn't mean they're irreconcilable. In 2015, the California Healthcare Foundation funded this little local company called Beyond Lucid Technologies to build it. We actually validated that bridge in the day before Thanksgiving, 2015, in Alameda County, California. I went to, not at this past NSEMSO conference, but the previous year's National State Officials, E.M.S. State Officials Conference. A certain vendor's representative literally got up in the room and said, well, every time you do a interoperability project, it's expensive and time consuming and it's sort of custom and you'd seen one. I literally stood up and said, it's so not true and you know it. This little dark cloud covered over his head. I want us to never have to go to a conference ever again and have to have someone say, this is so complicated. So instead, why don't we talk about how to do it? And then you can go back to your respective vendors, or if your vendors won't do it, I know one that will, and be able to talk to them about how you start to share this information. So when we did this gap analysis between the CCD, which is the oldest of the standard interoperable forms, and we picked on that because it's so old, but still structured under the meaningful use framework, that even hospitals and other facilities that have not updated their electronic health records since meaningful use stage 1, and we compared it with E.M.S.'s version 3. Is it stage 1 or stage 2, by the way? I think stage 1. No, the CCD. Stage 1, right. Let's make sure I get my facts right. So I can't really talk about facts and knowledge if I don't get them right? We found what I basically have estimated about an 85% overlap between the E.M.S. version 3 document and the CCD. And the CCD is by its own nature interoperable. And the gaps largely fell into 3 areas. Forget this one on the far right. Family history, mental health, and past visits. Think about that. What does it sound like to you? Community paramedicine? Isn't that what we're talking about? Family history, mental health, and past encounters. It turns out, in an incident-specific record, that's largely irrelevant, right? You go and you pick up a patient, and they're hypoglycemic, they're in insulin shock, etc. The fact that their dad had diabetes is probably irrelevant to the fact that they probably do. So you sort of stop there. But if you're looking at someone who is suffering from something chronic, the fact that they have a family history of XYZ might matter. Again, if they have stroke versus Bell's palsy, that could be an acute event. And knowing whether they have a history or risk factors for stroke could be all the difference between positively or incorrectly identifying what that syndrome is in the field. Now, you can err on the side of caution or too much caution, and you can assume that assume the worst, which might work. But in California, in Contra Costa County, California, my own county, which is not thrilled to me for picking on them, but the first white paper in your little book talks about something I refer to as perfect pre-hospital data. Back in business school, we talk about perfect data with respect to like finding oil in the ground. We don't really talk about that in terms of E.M.S. because E.M.S. doesn't share data with hospital, and hospital doesn't share data with E.M.S., right? What if you could? What if you could? In our county, 26 to 41% false activation rate of the cath labs. $5,000 every time they activate it. So I ran for office on the basis of this in my own county. Basically, look, $480,000 was the county's estimate of the amount we waste every year on false activations of the cath labs. You're not going to get it down to zero, but I can pretty sure there's some potholes that can be filled for $480,000, maybe $400,000. We have the technology to do this now. Why isn't this being done in the belly of the beast in California? We talk about interoperability and the ability, for example, and anyone in here served in the military? So thank you for your service. There are a few things that get me more riled up than the fact that in San Francisco, we have a couple homeless vets. And today, right now, even though the DoD and the Veterans Administration have the largest unified health system in the world, and veterans, and also just have a serial number, not just a medical record number, you have a tag number. We know exactly who you are forever. And unless it is the same two-man crew who responds to a patient who's seizing on the street, who is a homeless veteran, there is no way in San Francisco today of tracking that patient's information over time. Right now, the same place that built Twitter can't track patients who are being transported to the VA over more than one encounter. Oh my God, what are we talking about? So the ability to string data together over time requires adding some context to the NEMSIS record to allow it to be shared with the rest of the ecosystem. And then it requires folks being able to reach out. And by the way, I'm happy to talk a little bit more about that. I probably will as we go forward. But if you add to the NEMSIS version 3 record certain pieces of data that fall into these buckets, you end up with an interoperable document. And the funny thing is, and the neat thing is, you don't even necessarily have to put anything in that bucket, right? So let's say your patient is unconscious, right? You're not going to get a whole lot of family history out of them. Let's say the patient is altered mental state. You're not going to get a whole lot of family history out of them. Maybe you don't necessarily even need it for what you're responding to. But the fact that your document has those placeholders in it allows these guys to receive it. Because I'm just going to actually cite from your own website here, for example. I find myself demonstrating your website in more presentations than I ever would have fathomed in my life. EPIC's electronic medical record can consume any valid consolidated clinical document architecture, which is or clinical document architecture document, of which the CCD is the one that we use. There is a new one now, the consolidated clinical document architecture, the CCDA, which is a bit more flexible version of that, of the older structure, and something called FHIR. And so FHIR is where this comes in. FHIR, as I mentioned, stands for Fast Health Information Resources. This is the only community in which I would ever need to spell that out and point out that someone's not illiterate when they wrote that. But if you think about a PDF, right? So a PDF is basically a picture of a document, right? Unless you have certain software like Photoshop or something, you can't really do anything to edit it. And it's all or nothing. If you ever think about if you've downloaded a partial PDF and tried to open it up and it gives you an error message that says it can't open it, right? Because it's either all there or it's not all there. And there's not really any middle ground. The way that the CDAs are structured is the same. So they can be flexed in a number of different ways, which you get these different variants of. But you either are a CDA structure or you are not a CDA structure. And they really can't be given out in pieces. Right? This is where the trouble of data interoperability and of sharing data back from a hospital comes in. It's also why a lot of the claims by certain companies that you know to be able to receive data back out from an electronic health record in a hospital are complete and utter BS on a level that is so vitriolic you should throw those people out of the office if they just say, sure, we can do that. It's nonsense. It's technically impossible to do what they're offering to do unless you build specific custom bridges that tend to break every time an electronic health record system updates itself. Because the CDAs are all or nothing documents, when data goes in and gets formatted in such a way, there is not a way of giving you back only what you need. That's the problem. So if you think about it, if anyone's ever changed doctors, right, move from one doctor office to another, and you ask for your electronic health record to go with you, you either get a stack of papers or a flash drive, or more likely a CD with your information on it. Because the problem is there isn't a way of giving you, again, just what you want. So let's say you're transporting a patient with a suspected STEMI. Is the fact that 5 years ago they were in the same facility for a syphilis test relevant? Maybe. Look, in some cases it might be, but not necessarily. And because hospitals don't have a good way of giving you just what you need and keeping out things like mental health status and HIV status, which are separately protected under law, they clamp down. And this has been where HHS at the federal level, and I have friends who are the ones who issued this, so I want to be a little bit gentle here, but when they issued guidance loudly that said that hospitals have a right to share data with EMS providers, they're not wrong. That's just a legal answer. It's not a technical answer. So yes, you have a right to certain data. That doesn't mean you can get it, right? And so there has been a sub-industry within EMS that's grown up around the myth that you can simply plug something in and get data out of the electronic health record selectively. It doesn't happen. It can't, but it will. And this is where FHIR comes in. So FHIR essentially allows you to chop up the PDF. It's a query response language of which Epic was one of the first members of the Argonaut project, actually what they call themselves. So Jason and the Argonauts live again. And essentially what it allows you to do is say, give me the data only from what I need today, or whatever period I'm looking for. So if I'm looking for specific encounters and I want information about those specific encounters, only send me the equivalent of lines 1, 10, 12, and 47 of this PDF. I don't need everything else. Leave everything else out. Just give me that back. That standard is so new that version 4 of it, which according to the Office of the National Coordinator of Health IT, is the only one worth using. Everything before that was kind of test for the world to begin playing around in this. That only got cleared for distribution in January of this year. As of the December meeting of the Office of National Coordinator, it had been balloted in September. It was being cleared, it had been submitted in September, balloted in December, and approved for release in January of this year. So the ability for you to be able to go to an electronic health record and say, give me back only what I want, and give it back to me in a consumable digital XML-based fashion, is so new that our friends at the electronic health record companies have not generally deployed that across their services. Epic, Cerner, etc., are all working on this. This is critical stuff. It's just not yet there. So again, begs the question of, for everybody who's made promises to the market that they're kicking outcomes data back directly from EHR, what the heck are they selling you? What are they talking about? Without going into this level of detail, which tends to mean when I give presentations in my normal day job around these topics, they tend to not be short. Because folks want a yes or no, are you HL7 compliant? Can you kick us back our outcomes data? Okay. All you want is a yes? Sure, I guess. You have no idea what you're talking about. And I'm just going to tell you what I think you want to hear. I think that sucks. I'm going to show of hands, have you been interested in ET3? Okay. So while ET3 as a concept is sort of a complicated thing, let me skip ahead a little bit. I'm on my next slide. Actually, I'll go back to the one in a second. But ET3 and FHIR have an interesting relationship to one another that not a lot of people have been talking about. So despite the fact that, that we don't really know what ET3 means yet, and quite frankly, a lot of the places that need it the most, like rural America, are going to have the biggest trouble with it because there's a telemedicine component and can't get a cell signal, let alone, do telemedicine. What FHIR actually does, which is really, really interesting when it comes to data sharing, is it slims down by orders of magnitude the amount of information you need to share. Right. So if you think about how much data, say you guys connect to your EKG monitor, right? You're bringing in a ton of data off a data burst. So, if you're close to the computer and you're using Bluetooth, for example, it'll take its sweet time, but it'll get there. If you're on Wi-Fi and you got a strong connection, it'll get there a little faster. But if you're out in a slow connection area, right, and you're trying to send something to the cloud, you're going to be waiting a while. Wouldn't it be neat if you could only send what you need? And so I don't need all the stuff in the meter. I don't need the fact that I powered the thing on. I see the thing was on because I got a signal off of it. So, the ability to get down just to what you need is a really interesting and sort of still unspoken relationship between this future mode, potentially, of engage with the patient at their side and be able to get back the context that I need in a protected and safe fashion that is also informing that better care. And that is coming, but it's just from this January. We're only in June, right? So this is seriously new stuff. It's incredibly exciting to me that all of you are here for just this reason. But it's both exciting going forward and scary as to what has gone into the market today. What is just like the core measures in California that were being counted for a year and a half with mathematical errors in the system? What are we playing with right now? And how much time and effort and political capital is being spent putting E.M.S and hospitals in a room together saying, we want data back, we can't give it to you. Well, you don't like us. Why are we not important? No, you are. We just can't. And until we have this conversation around what the technical capabilities are, how can we have that conversation around what can be done?